very good morning to all of you. I am Dr. Suraj Pandey, Reader, Department of Periodontology, BBDCODS, BBD University. The topic for today's lecture is treatment plan. Now coming to the introduction. Now, what is the treatment plan? Now, after diagnosis and the prognosis is done, the treatment plan is carried out. Now, what is that? Now, the aim of the treatment plan is to treat the total patient, not only the specific complaint. Long-range treatment planning is always advocated. Now, what is long-range planning? That means to say that we are not going for the short-term goal. We are going for the complete rehab of the patient. Like suppose if the condition is there, that suppose if there is a tooth which has got a poor or hopeless prognosis, right? And to retain that heroically is a short-term plan, but to get it extracted and then going for a prosthesis is a long-term planning for the health of the patient. Now, the primary goal of the treatment is elimination of gingival inflammation. Now, as I said, long-range planning is to be done. Now, the treatment is directed to establishing the health of the periodontium of the entire mouth. Why? Because, as we all know, the periodontium consists of two hard tissues and two soft tissues, right? The hard tissues are cementum and annular bone, and soft tissues are the PDL and the lamina propria of gingiva. Now, this is the supporting apparatus of the tooth. Now, for either the tooth is to be used for mastication or for any prosthesis, that the periodontium should always be healthy. Also, if that we are going for orthodontic tooth movement, the periodontium is to be very healthy. That is why. Now, the next topic, that how do we explain the treatment plan to the patient? What are the key points which need to be considered to explain the plan to the patient? First point, be specific. Key points are to be mentioned to the patient. Don't be vague. Second, start on a positive note. Don't start with the teeth which you want to get extracted. Start with the tooth which you can save. Then present the entire treatment plan as a unit. Now, what is that? That whatever your total treatment, the long-term, entire plan as a unit, not parts of the treatment plan, part now, part later, no. Then explain that doing nothing and sitting at home is not advisable. Why? Always because the sooner we start, the better results we achieve, right? Now, coming to phases of periodontal therapy. Now, the treatment plan or the periodontal therapy is carried out in various phases. The first important phase, it's not the first phase, but it is the preliminary phase. It is also called as the emergency phase. Now, in this phase, there is treatment of an emergency, either periapical or periodontal. Now, what qualifies as an emergency? That any condition, for example, acute painful condition, which requires to be addressed first, leaving behind all the other conditions. Now, that is called as the emergency condition. For example, periapical, acute periapical abscess, periodontal, acute periodontal abscess. So these both are painful conditions which need to be catered to first. So that is what we cover in the preliminary phase. Now, if it is not required, we can mention not required. Now, next one, phase 1 therapy. Very important. Now, remember, it is the Roman 1, not the numerical, but the Roman 1. Now, phase 1 therapy has got several names. It is called as non-surgical phase. Why? Because the procedures here are of a non-surgical nature. It is also called as the initial phase because it is the first phase. It is also called as the hygienic phase because we make the patient realize the importance of hygiene in this phase. It is also called as Etiologic phase, because we remove the basic etiology of gingival inflammation or periodontitis as the plaque and calculus. It is also called as the cause-related therapy. So all these are several names of phase 1. So the short note on phase 1 can come on any of these names, right? Now the first point to be considered is plaque control and patient education and motivation. Now we use a disclosing solution, okay, and we demonstrate the mirror, we show the plaque pre and post applying, that how is the plaque in the patient's mouth. And then we educate the patient and motivate the patient, right? By telling him the importance of maintaining oral hygiene and teaching him different, whatever the brushing habit, for example, modified Bass technique, which is most commonly used in a regular patient. Now, the point to note is that what is the difference between education and motivation? Now, education is when you educate the patient, you tell the patient that this is the importance of maintaining oral hygiene or whatever. But motivation is when the patient does that in the absence of you. That means at his home. So if it is that, then your compliance is 100% success. Next step in this is removal of plaque and calculus. Next step is root planing. Now, any of the, we say, altered or necrotic cementum, which is altered, why? Because of endotoxins, are removed by curettes. Then any prosthetic irritational factor or any niche which is there, for example, any carious lesion is there, so we can do provisional restoration. So what we do is that any caries is there or any point is there for plaque retention, we have to remove that also. For then coming to the antimicrobial therapy. Now in this phase, we can do two types of antimicrobial therapy. First is local and second is systemic. Local means what we use as topical gels or mouth rinses, for example, chlorhexidine gluconate or povidone iodine, and provisional and systemic. Systemic. Why? Because there are certain diseases like aggressive periodontitis where we need to do a chemotherapy also on side by side. So we can give systemic antibiotics. So all this is done in this phase. So the basic aim of phase 1 is a very important phase 1. Aim is what? To remove the basic etiology, the basic cause, right? Now after this comes the phase 2. Now phase 2 is the surgical, again Roman 2. Phase 2 is the surgical phase. Now what is that? Now whenever the patient is having mild, moderate or severe gingivitis, phase 1 is enough to bring the patient to a normal condition if the patient is compliant enough. Now the problem comes when the patient is needing missing tooth and needs an implant or is suffering from periodontitis. More importantly, now periodontitis, the signs are tooth mobility, gingival recession, periodontal pockets, alveolar bone loss in the IUP or RVG. Now what happens is that in that case, we have to make the patient enter the surgical phase. Now surgical phase consists of either doing surgery for reducing or eliminating pockets, or soft tissue coverage, or periodontal regeneration, for example, with bone grafts, soft tissue or hard tissue regeneration both ways, or if the patient has a missing tooth, so needing of dental implants. So all these is done in the phase 2. Now coming to the third phase, again Roman 3, restorative phase. Now restorative phase is done in which all the, as we have mentioned, in the phase 1 therapy, we will be doing only provisional restorations. But here in this phase, all the final restorations, and the fixed annual process is to be delivered to the patient. Now coming to the phase 4, again Roman 4, it is called as maintenance phase, also called as supportive periodontal therapy. Now what happens is in this phase is that when the patient has done, everything has been done, we recall the patient for a periodic rechecking for the plaque or the condition of plaque and calculus deposits, gingival condition, whether there was bleeding on probing, so it has reduced or not, inflammation has reduced or increased. So pocket depths, again, increase or decrease, or mobility. The mobility is the upgraded or downgraded. So basically, we check the compliance of the patient in this. Now, always remember that this is the what we have mentioned, like phase 1, phase 2, phase 3, phase 4. It is the clinic, the what you write on paper, like it's the academic plan. Now, there's something called the clinical plan. Mein thoda sa difference ye hota hai, a slight difference is there, that phase 4 will come immediately after phase 1, and then the patient will escalate into the restorative or surgical phase, what if required. I'll tell you why. Suppose if the patient has come for missing teeth and wants dental implants, or the patient has come for a treatment of periodontitis. Now, what happens is that first of all, phase 1 is done, and then we have to wait and check whether the patient is complying or not. If the patient is not complying, phase 2 and phase 3 will be a failure. Why? Because of the accumulation of plaque and calculus. So what we will do is that phase 4, we keep immediately after that. That means say the patient comes, is put under phase 1 therapy, then put under recall maintenance phase. When the patient, you are satisfied, the doctor or the periodontist is satisfied the patient is well enough now to sustain the burden of phase 2 or phase 3, then the patient can go into that. That is the clinical protocol. Okay. So coming to the last part, conclusion, the most important point is that timing of the treatment. The dentist should always make it clear to the patient that if the periodontal condition is treatable, the best results are obtained by prompt treatment. Again, as we said earlier, sitting at home and doing nothing is not the solution. The more early you come to the periodontist, the more better it is for treatment. Thank you all for the patient listening.